We move ahead with the next, that's the state-of-the-art lectures. May I request our chairpersons to please make their august presence felt on the dais. Please welcome, in the order of appearance, Professor M.J. Gandhi, Professor H.K. Reddy, Dr. T. Alexander, Shashank Joshi, S. Vithanavasam, Professor Harshvardhan, and Professor Khalilullah. Our opening speaker is Colonel S.K.Parashar, the Chairman, Scientific Committee, and he'll be speaking on organic tricuspid regurgitation, emerged and emerging entities. And he'll have 20 minutes for his presentation. We'll have a full 10-minute discussion at the end of both the lectures. Colonel Parashar, please.
Well, the original talk was supposed to be given by somebody else, so I was asked to give this talk, that is an organic tricuspid regurgitation, emerged or emerging entity. Now, a few years back, we used to have these type of cases, and we still have those cases of a prosthetic mitral valve with a huge right atrium. The tricuspid leaflets failed to coapt in systole. Possibly either the surgeons were less confident in doing it, this tricuspid thing, or possibly many of the indications were not clear, and many of these patients went into cardiac failure, and nothing could be done because, as you know, if you operate on a isolated tricuspid regurgitation, the mortality is quite high. And these patients had a very severe tricuspid regurgitation. So from that time onwards, the concept, the most stress was placed on an organic tricuspid regurgitation, and like a mitral regurgitation, the tricuspid regurgitation can be broadly classified into primary, that is organic, which is related to pathological involvement of leaflets and chordae, and secondary, of course, functional, which is still very common. About 80% of TRs are because of functional, because of a simple annular dilatation, often associated with pulmonary hypertension, RV remodeling, left-sided heart disease, atrial fibrillation, etc. Now, why tricuspid lesions have been missed before also is the lesions are mostly asymptomatic because they are associated other lesions present. So they are relatively asymptomatic, and they are usually missed on auscultation due to other concomitant valvular lesions which overshadow them. And number three, see the stalwart sitting here, the auscultatory skills are decreasing over a period of time because of over-reliance of non-invasive and other investigative pathologies. Nowadays, patients are directly referred without even a stethoscope being put, and many a times, these lesions are detected on a routine echo which is done for other indications. So for many years, it was considered to be functional, but nowadays, now it has gained a more significance because the persistent, moderate to severe organic tricuspid regurgitation impacts the functional capacity. The functional capacity is significantly reduced, and there is a medium and long-term survival is also effective in these cases. This is a sort of a difficult slide for me. Why is TR important? It is a progressive lesion. When there is a tricuspid regurgitation, it leads to an RV-RA dilatation because of volume overload. A persistent RV-RA dilatation leads to an RV dysfunction. There is an increase in the RV diastolic pressure, as a result of which, because of a ventricular interdependence, there is increased LV pressure, and it tends to lead to various other things. Now we'll go to some of the cases mainly, rather than going into theory. Say now, because we were avoiding this thing, this was a paper from a G.V. Pant hospital, which was published in JACC 2012. They had a large number of rheumatic cases, and they found that the organic tricuspid disease is found in about 18.3% of cases, and in 9.9% of the patients had an organic TR. And most of them were moderate and severe. So that gave us an impetus to everybody that whenever you do a routine echo or see everything, don't neglect the tricuspid valve and always examine this. Based on this, this was one of the cases. You can see a very calcified aortic valve, mitral valve in a short axis view, and there is a marked thickening, calcification, doming, and restricted opening of the tricuspid valve, indicative of a tricuspid involvement. I think many of these cases might have been missed before because of this not being involved. And again, you can see on a color flow mapping, severe tricuspid regurgitation and tricuspid stenosis, giving a diagnosis that yes, the patient has a rheumatic involvement, which is an organic involvement of the tricuspid of the ball. Now, RV dysfunction and TR has been found to be more common in mitral valve disease, and the more longer the clinical course, it leads to more clinical and hemodynamic deterioration. And we should avoid, why we should go on giving importance to an organic tricuspid lesion, we should avoid an RV dysfunction because the operative mortality increases from 5% to 11%, and during follow-up, it may increase from 8 to 22% if there is the development of an RV dysfunction. So the few key points in management, as I mentioned, that TR is more common in mitral valve lesion. In these cases, interestingly, it has been shown by histopathological studies and some post-mortem studies that in all these cases, TR may not always be functional because it has been shown that there can be pathological involvement of the annulus. And that is why many times when you correct the mitral valve, the TR may not be corrected because there is a pathological involvement of the annulus. And the repair outcome is worse in an organic TR as compared to a functional TR. Similarly, a dilatation of the tricuspid annulus is a progressive problem and may not be accompanied by TR. Sometimes there may be mild or minimal TR. That is why a prophylactic intervention is now being done. Initially, it was found when the TR annulus was more than 4 centimeters. Now persons have come at 21 millimeter meter square or more than 3.5 centimeters. Also, they said, please do a prophylactic intervention. Or during surgery, if you find an annulus more than 7 centimeters. Annuloplasty achieves an excellent result. Ring annuloplasty for organic TR. Prosthetic valves usually on the right side have got a poorer outcome with a 20%, 5% chances of prosthesis. So that is why the main summary is that never neglect a tricuspid valve and always see that there is no RV dysfunction. Now, we have been seeing a lot of congenital cases which has not been diagnosed before. This was a 30-year-old female, dyspnea on exertion since childhood, exertional cyanosis since childhood, and she sought when there was increasing complaint, she sought consultation, a cardiac cath was done, but no papers were available. Only she had one paper which mentioned that there was a balloon dilatation of the pulmonary valve was done and nothing else was known to us. She was lost for follow-up and surprisingly had a normal delivery 7 years back. Then she came to us with a sort of a slight dyspnea, clinically normal build, growth and development was normal. There was clubbing of the nails, no cyanosis, there was no pedal edema, prominent A wave was seen in jugulars, and a systolic murmur was heard in a left sternal edge upper and possibly a diastolic rumble at the left lower sternal edge. Of course, a pulmonary valve Doppler revealed a peak gradient of about 35, indicating that yes, there was a pulmonary stenosis. And then we went to the 4-chamber view, and you see a very markedly enlarged right atrium. There is a very marked restriction of both the anterior and the septal leaflet of the tricuspid valve. The right ventricular is relatively underdeveloped because of 2 reasons, because of a congenital slight underdevelopment of RV, and number 2, because of stenosis leading to a less filling. So this gave us a diagnosis, and a color flow mapping showed a moderate TR and also the evidence of stenosis. And there was a significant gradient across the tricuspid valve, so that there was an associated TR and TS with congenital duration. And being an adult, a very difficult thing, we could show a small right to left shunt through a stretched foramen ovale. So the diagnosis was a congenital tricuspid stenosis plus TR, almost which never occurs in isolation, and residual post-balloon pulmonary stenosis and a bidirectional shunt. The incidence is very less, hardly 0.3% of CHD, and usually associated with RVOT obstruction, which was present in this case. Another patient, unfortunately, we could not follow for a long time, a young male with dyspnea. You see on the right side, you see the tricuspid leaflets are significantly thickened, and it is a zoomed view, restricted motion, all left-sided There is no left-sided disease. Every other possibility, every other findings are normal. So there was an isolated involvement of the tricuspid wall, and on a color flow mapping, you see a severe TR present associated with some stenotic lesion. So that means there was another cause of an organic TR due to a congenital lesions, and of course significant gradients were increased. So we have seen cases, so we have not to ignore them. A 65-year-old lady, dyspnea on exertion, recently increased, X-ray chest shows cardiomegaly. We tell our residents what is known as a Y syndrome. Y syndrome means that if you find an abnormal finding, why is it? If you consider why, you will never miss a lesion. So this patient came with a pericardial effusion. You see a pericardial effusion present, but why the RV is significantly enlarged? Or if you miss it, you miss a Y syndrome. In a short access view, you see a diastolic flattening of the interventricular septum, indicating of a diastolic overload together with a pericardial effusion. So with this Y syndrome in our mind, we went to the apical view, and suddenly in a 65-year-old lady, we find the presence of an Easton's anomaly. You see a very large sail-like anterior septal leaflet, an apical displacement of the septal leaflet, and you see the TR will be coming right from there, and the distance from the mitral annulus was about 41 millimeters, normal meaning about 15 to 20. So we have not seen a 65-year-old lady having Easton's anomaly, and you can see an apical tricuspid regurgitation present. And it is found in about less than 1% patients with a congenital heart disease also. So that was the importance of a Y syndrome. Now a 25-year-old female had a uterine sepsis following a home delivery, fever, dyspnea, chest pain, no hemoptysis, and she was clinically toxic, tachycardiac, tachypneic, febrile, pedal edema, systolic murmur, left sternal edge, and you see a very huge, big vegetation in relation to the tricuspid wall. It is producing almost a completely flail leaflet with a severe tricuspid regurgitation, and you can see whole of this, and this was more of a staphylococcal thing, and presence of a severe tricuspid regurgitation following a flail leaflet. Now, the right-sided endocarditis have got usually less incidence because the relatively infrequent occurrence of right-sided congenital disease and RSD, and it is a low pressure, low oxygen saturation system, and mostly involves a tricuspid wall, like a drug abusers. Now we see in our country also pacemakers, defibrillators, and CV line. Now this patient refused surgery, so she was treated medically, and she had a good response, but a surgery is usually indicated when there is an uncontrolled sepsis, intractable right heart failure, paravalvular abscess, fungal endocarditis, and vegetation more than 20 millimeters. So because of this persistent infection and very large vegetation, she refused surgery, but somehow she could be managed by this. Now, this is a case given to me by somebody, not my personal case. It is a 58-year-old male, interesting case. He was on a pacemaker implantation for a 6 sinus syndrome. He had a fever for 2 years, intermittent, with a variable diagnosis. For 2 years it was going on, and had multiple antibiotics, given a full course for tuberculosis, given a full course for malaria, given a full course for enteric fever, and the fever went on for about 2 years. A transthoracic echo was done several times, but could not visualize any mass across the tricuspid valve. As a result of which the diagnosis was missed. Even when it was done at one of the centers, you can see the right side, you can hardly see anything. And you can any diagnosis, and when a transesophageal echo was done, it shows a multiple vegetations in relation to the pacemaker lead and also the tricuspid valve. So it was only a transesophageal echo which gave a diagnosis of a pacemaker lead endocarditis and the presence of a significant lesion. And while awaiting decision for surgery, he had a septic embolization to right lung, pulmonary infarction, and right-sided pleural effusion. Then he was operated. The whole pacemaker was removed, and the information given to me, he was not found to have a sick sinus syndrome. After a full investigation, there was no sick sinus syndrome. So the pacemaker lead endocarditis, it is a rare and serious implication, incidence 0.13 to 7%. Commonest entry point of bacteremia is subcutaneous generation pocket. Absence of local or systemic signs of infection gives a problem in diagnosis. Transesophageal echo is diagnostic in more than 96% of cases, and entire removal of pacing system is the treatment of choice. A 45-year-old male, fully asymptomatic, referred for a cardiac murmur, left sternal edge, ECG, right bundle branch block, as usual, diagnosed at ASD, had a vague symptoms, which became asymptomatic. He continues to be asymptomatic, clinically normal build, not dyspneic, normal BP, hyperdynamic RV impulse, a 3/6 systolic murmur, left sternal edge, and as you see on a parasternal long axis view, the RV is significantly enlarged, and whenever we get a significantly enlarged RV, we think of either a pressure overload or a volume overload or some myocardial disorder. So there's significant RV overload, and when we came to the apical view, you see a completely flail anterior tricuspid leaflet. Completely flail, nothing, no fever, no toxemia, nothing. And you see the subvalvular apparatus is also coming back with the anterior mitral leaflet, and this is the zoomed view, and the zoomed view shows a completely flail anterior leaflet with the subvalvular apparatus also coming by coming back into it. And this led to a severe tricuspid regurgitation. So the question which came out of my mind, what is the diagnosis? Why is the patient asymptomatic? Asymptomatic was all right because there is no pulmonary hypertension. We did a right ventricular function which was normal as known by a tricuspid annular plane systolic excursion. The more the motion, the better the RV function, and a normal tissue Doppler. But the question was, what is the cause of this completely flail leaflet and with no other associated features? So we went to the detailed history, and it was found that in 1990, he was waylaid by personal enemies, fell from the motorcycle, and was repeatedly beaten very badly, and that gave us a diagnosis that this was a case of a traumatic tricuspid regurgitation. And isolated traumatic regurgitation is a rare complication of blunt chest trauma. It is initially overlooked due to other concomitant multi-organ injuries, and hence it may remain asymptomatic, as was in this case, as long as they are hemodynamically well maintained, and cases have been seen who have been diagnosed 11 to 40 years after a blunt chest trauma, and they have been operated. And these are some of the mechanisms of this, which we're not going to detail. And so there can be a laceration of the wall, there can be a rupture of the papillary muscle chordae, which was present in this particular case. So the take-home message from this case are that chest traumas are getting very frequent due to more accidents, due to anterior location of RV. Focus on the tricuspid wall should always be there, and various subvalvular apparatus, and this also should be seen carefully. Middle-aged man presenting with episodic palpitations, labile hypertension, shortness of breath, but his main complaint was abdominal cramps and diarrhea. He had, because of abdominal recurrent of diarrhea, he was diagnosed as an irritable bowel syndrome, even have all these gastrointestinal symptoms, but when nothing was found out, and because of these complaints, he was sent for echo, and echo gave a immediate diagnosis. As you see, the septal leaflet is completely plastered to the interventricular septum. The two leaflets, tricuspid leaflets, failed to coapt in systole. There is severe tricuspid regurgitation. The pulmonary valve is thickened, and you can see there is no other lesion. So the involvement, severe involvement of the right-sided valves associated with these symptoms gave us a diagnosis of a carcinoid syndrome, especially these tricuspid lesions. And because of a increased level of serotonin, and because of a hepatic metastasis, the serotonin is not degraded, and it involved the right-sided valves, as are present in this case. And besides echo, the urinary 5-hydroxyindole acetic acid was about 75 milligram 24-hour urine when the normal is about 25. As my time is finishing, we don't want to show this was just a right-sided endomyocardial fibrosis, a rare combination of right-sided endomyocardial fibrosis with mitral stenosis presenting with a severe mitral regurgitation. So scan carefully tricuspid wall during any echo examination. We had more cases, but we had restricted because of time. Most it may be silent lesions and liable to be missed. More cases of organic TR are being recognized. They have a significant prognostic and therapeutic significance. Avoid progression to right ventricular dysfunction. Thank you very much.
Thank you, Colonel Parashar. Please have your seat. We'll come back for a full-fledged discussion with both the speakers at the end of the next lecture.